Okay, welcome. My name is Divine. This is episode 432 of the Divine Intervention podcast. In today's podcast, I'll be discussing a topic I like to call Blitz, Pharmacology Blitz. So I know some of you may wonder, Divine, what do you mean by Pharmacology Blitz? Basically, what I mean is, over the next few minutes here, I want to try to cover a lot of very high-yield pharmacology that will be helpful for anyone taking step 1, step 2, or step 3. I'm just going to try to tie many things together. So I'm not going to dwell too much on any one point. It's going to be almost like a rapid review of pharmacology. Obviously, I can't cover every single pharmacology in this one podcast. But at least I will try to make an attempt to cover as much as is humanly possible. So what if they give you a question about a patient and they tell you that this patient has a myocardial infarction and the person got a drug for chest pain and then the person's blood pressure decreases precipitously? What should you be thinking about? I really hope you're thinking about a nitrate. Remember, nitrates, they are very important drugs that are used in MIs to deal with the chest pain because, when you have an MI, your heart is not working very well. So you need, as those myocardial cells are dying, you may experience a lot of pain. So that pain, one of the ways we treat that pain is with nitrates. And nitrates, they help by being powerful vasodilators. Since they are powerful vasodilators, they would send less preload to your heart. So your heart doesn't have to work as hard since it's dealing with less fluid, and they will help. That's how nitrates help, especially even in people that have angina. They reduce myocardial oxygen demand. But if you have an RCA infarct, nitrates are not a good idea. They are not a good idea. So remember, nitrates, again, they cause nitric oxide release. Okay, maybe let me explain. So they're not a good idea because in RCA infarcts, you need preload bad. So if you're taking a vasodilator, you're killing that preload, you're going to get in a lot of trouble because those people are effectively not taking blood to the right side of the heart. But that right side of the heart is already dysfunctional because they have an RCA infarct. That's what caused this precipitous drop in blood pressure in this patient. So remember, nitrates, they work by causing nitric oxide release. So they cause a lot of vasodilation. Again, they are predominantly vasodilators. And don't forget, they work primarily through the cyclic GMP system. The cyclic GMP system. So they cause vasodilation. But again, more specifically, they work in veins than arteries. And remember, these things, because they are very powerful vasodilators, they can cause a lot of hypotension, cause a lot of flushing, cause a lot of headache, right? Remember, headache is mediated by vasodilation. I believe that's a mechanism I've explained. I guess I'm kind of catching myself going off in all these directions now. But I think it's just better than just flying through things. Let me just make sure that you can understand at least even the little I talk about. I've used this principle before. Again, I'm going to try to integrate with other drugs. I've discussed this principle before, I believe, in an older podcast that vasodilation causes headaches, vasoconstriction treats headaches. For example, I like to think of it this way. Nitrates, they are vasodilators. They can cause you to have headaches. But look at people, when you have a headache, what do you take? You usually take an NSAID. How do NSAIDs work? NSAIDs are cyclooxygenase inhibitors. They inhibit cyclooxygenase. When you inhibit cyclooxygenase, you'll make less prostaglandins. Prostaglandins are vasodilators. So you're making less of a vasodilator. By making less of a vasodilator, you're going to get vasoconstriction. If you also look at it from the perspective of migraines, like taking drugs like the sumatriptans and the ergotamines, those things are very powerful vasoconstrictors. They're very powerful vasoconstrictors. Remember, those drugs, by the way, especially sumatriptan, is a serotonin agonist. It's not going to be a very good idea in a person that is taken as serotonergic agent. So just be careful there. Sumatriptan can be a cause of serotonin syndrome in a patient. Just be mindful of that. So those drugs, they're very powerful vasoconstrictors. Since they're powerful vasoconstrictors, they're very helpful for reducing the migraine problems that people could have, because again, you're essentially causing a vasoconstriction in the brain. And then that should inform you why people that have a history of vasospastic disorders should not be on drugs like sumatriptan. It will not be a good idea, because again, if you have a vasospastic disorder like Prinzmetal angina, which we call variant angina these days, or you have Raynaud's phenomenon, just if you have vasospasm in a vessel, it's not a good idea to be taking sumatriptan, because again, those things, just as well as they cause vasoconstriction in a person's brain, they also cause vasoconstriction in the periphery. That can cause problems if you have vasospastic disease. So again, I guess we've kind of talked about 4 or 5 drugs just from talking about nitrates. But again, nitrates, we use them for angina, and you get tolerance to nitrates very quickly. That's why it's very important to take like a drug-free holiday of some sort. Now, what if they give you a question about a person that is on a bunch of cardiac drugs, and you notice, let's say they have metabolic disease or diabetes or whatever, and then you notice that those people have red urine? Well, again, I really hope you're thinking about statins. So remember, how do statins work? Statins, they inhibit HMG-CoA reductase. They inhibit HMG-CoA reductase. So because they inhibit HMG-CoA reductase, they're going to prevent the synthesis of cholesterol. That's how they're hypolipidemic agents. They're basically going to reduce the synthesis of LDL. So if you reduce the synthesis of LDL within the hepatocyte, for example, then the thing that's going to happen is your intracellular hepatocyte LDL concentration goes down. So your body is like, man, I'm going to need more LDL from the periphery. So you're going to express more LDL receptors on the surfaces of your hepatocytes, and that's going to cause you to bring in more cholesterol, more LDL cholesterol into the cell. And if that happens, then your blood cholesterol levels are going to go down. Remember, the statins, they're the best at reducing LDL. But don't forget, these things, they are going to decrease the synthesis of coenzyme Q, so you can have some muscle dysfunction. If your muscles are not working properly, you're going to have rhabdomyolysis. Those muscle cells are going to start breaking down. If they break down, you're going to have red urine. You're going to be seeing a lot of myoglobin in the urine. So you're going to see like 3 or 4 plus blood, but you're not going to see a commensurate number of red blood cells because of that statin-induced toxicity. So that's something you kind of want to make sure you keep at the back of your mind for exams. And then, what if they give you a question about a person that is taking a supplement because they want to try to get healthy? Because let's say your doctor told them that, your LDL is really high and your HDL is really low. So they started taking a supplement. Well, I really hope you're thinking about niacin in that circumstance. So niacin, remember, it's very good at lowering LDL, but it's the best at raising HDL. In fact, one thing our friends at the MBMEs love to test on exams is they love to test who is the best at doing XYZ. There are certain things you need to know here. In terms of lowering your LDL, statins are the best. In terms of raising your HDL, niacin is the best. In terms of lowering your triglycerides, your fibrates are the very best. Your fibrates are the very best at lowering your triglycerides. Just want to keep that in mind for your exams. So remember, niacin, again, it's the big thing there. The big story there is raising HDL. And again, the thing is, niacin can cause flushing. Niacin can absolutely cause flushing. One of the easy ways to remember that is that if you think of a person that has a lot of serotonin being made in their bodies because they have carcinoid syndrome. Remember, one of the things that happens with carcinoid syndrome is that they have bronchospasm, they have flushing, they have diarrhea, and they have right-sided heart problems. Flushing because they have that serotonin excess. Well, where does serotonin come from? Serotonin comes from tryptophan. And niacin is also derived in a way from tryptophan as well. So you can kind of see an interrelationship there. That may be the easiest way I would say for you to remember that when a person takes a lot of niacin, they can actually get flushing as a side effect. And then what if they give you a question about a person and they tell you that this person, they were started on statins for their diet for hyperlipidemia, but their LDL was not brought to an acceptable range, so another drug was added. But since that drug was added, they've been having a lot of foul-smelling stools. They've been having a lot of floating stools. Well, if you see stuff like that, I want you to think about the bile acid binding resins. So something like cholestyramine, cholestyramine, cholesevelam. These are bile acid binding resins. So they basically bind bile acids in your GI tract, in the lumen of your GI tract, which is good because if you bind those bile acids, then you're basically messing up this process of enterohepatic recirculation. If you remember, maybe from early med school, you probably remember learning about this thing known as enterohepatic recirculation, where you basically start with some of the bile you make, you're going to actually reabsorb some of it in the GI tract. So the thing that happens is if you bind up the bile with the bile acid binding resins, like cholesterol, cholesterol, or cholestyramine, you're not going to recirculate it back. You're not going to reabsorb it back. So if that happens, it's almost like, if you're thinking in terms of Le Chatelet's principle, you're driving the more excretion of bile acids. So your body is going to be like, wow, I'm not seeing bile acids here. Let me keep making more, keep making more. And as you make more and more bile acids, where do you think bile acids come from? They come from cholesterol. They do come from cholesterol. They do come from cholesterol. So in that way, you're going to be lowering your cholesterol in your body. And progressively, because it's almost like I just think of it as an equation. Bile acids on one side of the equation, cholesterol on the other side of the equation. If you keep those recirculating bile acids, almost keep like a equilibrium of some sort. So your body is going to be like, wow, okay, these bile acids, I'm not seeing anything on the other side of the equation. So I'm going to keep driving their formation. So if you're driving the formation of more and more bile acids, well, guess what? You're going to be utilizing your cholesterol more and more. So you're going to be lowering your cholesterol more and more. That's literally how bile acid binding resins work, and actually being very good for lowering a person's LDL, for example. But again, you can already begin to see that this could potentially cause problems. Because if your body is then generating more and more bile acids, well, remember those bile acids are generated in your liver. And all those bile acids are going to be excreted into bilirubin. They're going to be excreted into the stuff that comes out through your ducts, your biliary system, all the way to the duodenum. So if you're making more and more bile acids, those bile acids that you're making more and more of, because your body is like, wow, I'm not seeing them being recirculated back. You're making more and more of them. It can saturate your biliary fluid, and you can get gallstones. You can get those depigmented, those unpigmented gallstones. And again, obviously, bile acids, if they are hanging out in your GI tract for longer than they should hang out, it's going to cause you to have a malabsorption. You're going to have a nasty diarrhea. So it's not necessarily the best thing in the world. And then don't forget that cholestyramine is actually a very good adjunct you can add in a person that has C. diff colitis. It's actually very good at binding up the C. diff toxin. So if we're talking about C. diff, what do we use to treat C. diff? Well, remember, we treat C. diff with oral vancomycin, or you can use fidaxomicin. Vancomycin, you're going to give it orally because it has to concentrate within the lumen of the GI tract to kill the C. diff. It has to concentrate within the lumen of the GI tract to kill the C. diff. So I guess my question for you then is, how does vancomycin work? How does vancomycin work? Well, vancomycin, the way it works is that it essentially binds to diala-diala. And when it binds to diala-diala, which is found in the cell wall of especially your gram-positive organisms, it binds to diala-diala. When it binds to diala-diala, then your enzymes that help you build your cell wall, like transpeptidase, they will not be able to bind to it, because literally transpeptidase, its job is it takes diala, kind of brings them together, and boom, makes a new cell wall. But if for some reason there's someone hanging out on diala and transpeptidase cannot bind to it, then you're going to get in a lot of trouble. Not you, but those bugs will get in a lot of trouble. So the critical thing then is, our friends at the MBMEs, they can then say, okay, well, you know the mechanism of action of vancomycin, great. And then they give you a question about a person. They tell you that the person has a significant gram-positive infection, gram-positive sepsis, and the person got vancomycin. But days after getting vancomycin therapy, the person's clinical condition is getting worse. They're still having fevers, they're still having leukocytosis, they're still having all these problems. And then they can see what's the most likely etiology of this phenomenon that you're observing. But I would really hope you're saying that diala was converted to diala-dilac, right? So again, remember, you need two alanines next to each other for vancomycin to bind. If you have alanine and lactate next to each other, then vancomycin cannot bind. That's how you get vancomycin resistance. That's how this whole term of VRSA, vancomycin resistant Staph aureus, or VRE, vancomycin resistant enterococcus, kind of comes to light. So that's something you want to keep in mind. Again, you want to be able to integrate these things together. You want to be able to put all these things together. So that's how vancomycin works. That is exactly how vancomycin works. And then what if they give you a question about a person? They tell you that this patient comes to the emergency room because they've been having epigastric pain that radiates into the back. And then they tell you that this person does not have a history of alcoholism, but that the person is very obese. And then you notice that this person's triglyceride is in the thousands. Well, what's going on there? Well, I hope you're telling me that, oh, Divine, this sounds an awful lot like hypertriglyceridemia induced pancreatitis. So what are we going to use to treat hypertriglyceridemia induced pancreatitis. We're actually going to go ahead and use a fibrate. Remember, fibrates, they have like a pretty classic naming scheme. They all end in either fibrate or they end in fibrosel. So like fenofibrate, clofibrate, gemfibrosel. Those are their classic names. And remember these things, how do they work? Well, the way they work is that they upregulate lipoprotein lipase. So by upregulating lipoprotein lipase, lipoprotein lipase, what in the world does it do? Its job is to break down triglycerides. So if you break down triglycerides more and more and more, then you reduce their levels. Because remember, hypertriglyceridemia can absolutely cause pancreatitis. Again, don't think only of gallstones and alcoholism as the only causes of pancreatitis you could see on your exams. There are many things that can cause pancreatitis. There are drugs that can cause pancreatitis, especially some of the diabetes drugs, your GLP-1 agonists, your DPP-4 inhibitors, they can cause pancreatitis. Your HIV drugs, stavudine, didanosine, they can cause pancreatitis. Mumps the virus, so they can give you a question about a child with big jaw and big testicles. And of course, they'll put Fragile X syndrome as one of those answers, which will be wrong. But then they'll put mumps. Mumps can also cause acute pancreatitis. So remember, there are many things that can cause acute pancreatitis. But hypertriglyceridemia, remember, even acute pancreatitis, they can give it to you as a question. And I'll get back to the fibrates in a bit. But again, I'm trying to make some more integrations here. But they can give you a question about a child that hits his belly on a table, and then they start having this epigastric pain radiating to the back. Again, that can be a cause of pancreatitis. Remember these handlebar injuries. If you hit your belly, especially your epigastrium, very forcefully on a hard surface, that can cause it's like blunt force trauma to the pancreas. That can absolutely positively cause acute pancreatitis. This is something you just want to keep at the back of your mind for exams. So remember, fibrates, how do they work? Again, fibrates, they upregulate lipoprotein lipase. Remember, lipoprotein lipase, its job is to break down triglycerides. So if your lipoprotein lipase is revved up, your triglycerides are going to go down because they are being more effectively metabolized. But again, remember, these drugs, they can cause a myopathy, just like statins. They can cause a myopathy. In fact, combining a statin and a fibrate is usually not a stellar idea on the USMLE exams because that can absolutely cause problems for the patient. So remember, statins and fibrates, they can cause a myopathy and they can also be hepatotoxic. To be honest with you, some of you may be like, Divine, how do you remember these side effects so well? To be honest with you, sometimes one of the best ways to remember side effects of things is to just remember what organs where does this drug actually work? Like, for example, I'll give you a classic example, like metformin. Many people are like, oh, gee, if your liver doesn't work, well, can't take metformin. If your kidneys don't work, if you have like chronic kidney disease or whatever, can't take metformin. Why do you think that is? Well, ask yourself, how exactly does metformin work? We know that metformin works by inhibiting hepatic gluconeogenesis. Basically, the big thing to know about metformin is that it inhibits gluconeogenesis. Okay, well, let me ask you a question. Where in the world does gluconeogenesis happen? We know that gluconeogenesis for sure happens in the liver. And we also know that gluconeogenesis for sure happens in the kidneys. Many people forget this, but the kidney is actually capable of gluconeogenesis. They are capable of making glucose that can be distributed to other organs in the body. They're capable of doing those things. So if we know that metformin sites of action primarily are in the kidneys and in the liver, then it would make sense that if your kidneys don't work well or your liver doesn't work well, you're going to be predisposed to metformin toxicity. And since we've kind of talked about metformin, remember, sometimes instead of putting metformin as an answer on the exams, our friends at the MBMEs, they love this whole concept of derivatives. They're going to use the term big one-ites. That's the drug class for metformin. Again, our friends at the MBMEs, they just occasionally like using terms that are different from what you're used to. So don't forget, metformin can essentially inhibit gluconeogenesis. So if it inhibits gluconeogenesis, then it's basically increasing your glucose sensitivity in a sense. Actually, there's another thing there with an AMP-dependent kinase that metformin also activates. That AMP-dependent kinase makes your body use glucose without insulin. Because remember, the big problem with diabetes is that your body is unable to use insulin effectively. You either have no insulin, that's type 1 diabetes, or you have an insulin resistance, that's type 2 diabetes. Although over time, if you have type 2 diabetes, amyloid is going to build up in your pancreas in the form of amylin, and then it's going to mess up your pancreas. So you're going to at some point develop an insulin deficiency. That's why if people have type 2 diabetes for long enough, they're going to need insulin at some point. So the thing is, metformin essentially provides your body an alternate pathway to utilizing glucose in a non-insulin dependent fashion. That non-insulin dependent fashion is by this AMP kinase. AMP kinase is a kinase that causes you to use glucose without needing insulin. Literally, without needing insulin. If I'm not mistaken, I actually believe that AMP kinase is something that comes into use when you're exercising. Because when you're exercising, you need a lot of glucose, and you need that glucose really fast. So, your body, one of the ways it tries to really rev up how much glucose you have available is by using that AMP kinase. That AMP kinase is actually upregulated when you exercise. That's actually a truism. I don't know if truism is a term, but whatever. But essentially, if you're using that AMP kinase more and more, then it's almost like your body is able to deal with that hyperglycemia problem that you have in diabetes, but it's not using insulin to do that. So in that case, you become more insulin sensitive. In that case, you become actually less dependent on insulin because your body is like getting all this good utilization of glucose, even if your insulin may be very limited that is around. So that's how metformin actually increases insulin sensitivity. And that's also why if you exercise, you can actually reverse diabetes, because by exercising, you're going to upregulate more AMP kinase. And by upregulating more AMP kinase, you're going to be utilizing glucose more effectively. If you use it more effectively, then you're not going to have that much of a blood sugar problem. And that can actually really help over time in diabetes, especially when you do it with some level of consistency. So many people also memorize that, Divine, I've learned that metformin can cause lactic acidosis. Well, let me ask you this. How do you think it causes lactic acidosis? Well, think about it. Again, it all comes back to understanding the biochemistry. We know that metformin inhibits gluconeogenesis. So because metformin inhibits gluconeogenesis, think about it. When do we upregulate gluconeogenesis? We upregulate gluconeogenesis when we're in situations where we don't have enough energy. And lactic acid is a good marker in the body for not enough energy. It's a good marker in the body for not enough energy. Because if you think about it, why would you be generating lactic acid? You'll be generating a ton of lactic acid because you've depleted, you've been running. It's almost like you're like, man, I need energy bad. So you know what? Even if I cannot do oxidative phosphorylation, I'm going to at least do glycolysis and make a lot of lactic acid. So what does your body do with that lactic acid? Well, your body takes that lactic acid, converts it back to pyruvate, and then takes it up that gluconeogenesis pathway to go back and reform glucose in the process of gluconeogenesis. So think about it. If you shut down gluconeogenesis, then everything that feeds into that gluconeogenic pathway is going to start building up. It's literally going to start building up. And if those things start building up, that's going to cause you a lot of problems. It's going to cause you a lot of problems. I mean, one of those things that can build up is lactic acid. One of those things that literally can build up is lactic acid. So that can cause a problem. That's actually how metformin causes a lactic acidosis. That's a logical way to visualize it in your mind. And one thing I want to say real quick before I continue is, again, if you like the way that I integrate things, then you may be interested in some of the review courses I offer. For people that are taking the USMLE Step 1 exam, I actually have a course coming up next week. Actually, I believe starts next week, Thursday. It's going to be from the 5th to the 7th of January and from the 9th to the 10th of January. I believe we're going to do it Thursday, Friday, Saturday. And then we're going to take a break on Sunday, and then we're going to meet on Monday and Tuesday. It's 5 hours each day, it's 25 hours total. And again, if you like the way I integrate things across many disciplines, the way I present things in a form that is not just a lecture, but I present it with clinical context and scenarios, then that Step 1 class may be something that you're looking for. It's a 25-hour class. And also, if you're a person that just is taking Step 2 or Step 3, and you have an awful basic science foundation, the Step 1 class is precisely what you need. And then, by the way, I also have a few other classes running in the month of January. I have an MBME test taking strategies class. It's for Step 2 and Step 3, but it's also intended for people taking Step 1, because Step 1 has a lot of clinical questions. Analyzing those clinical questions appropriately, this test taking strategies class will help you for that. That's going to be taking place on the 20th of January. And then I have a social sciences and ethics class. It's a 5-hour class taking place on the 12th of January. Social sciences and ethics for all the USMLE exams. exams. It's now about 10 to 20% of each form, of each exam. So if you want to get a very solid basis, and again, I'm not going to be giving lectures, I'm going to be presenting scenarios and showing you how to apply and integrate the knowledge, then this class may be something you're looking for. And then I have the 20-hour review course. That's for step 2 and step 3 and complex 2 and 3. Also, if you're a medical student, you're a third-year med student, you're like, you know what, I want solid prep for all my shelves. I want to see a lot of the high-yield information that will show up on my shelf exams. Then the 20-hour course is what you need. It's going to be taking place on the 23rd and 24th, and on the 26th and 27th of January. It's 20 hours, 5 hours, 4 days. 5 hours each day for 4 days. And then, I also have the biostatistics bootcamp, which is very popular. Many people have taken it and they found it to be tremendously helpful. It's going to be held on the 30th of January. It's going to be held on the 30th of January. So if you're interested in any of these classes, just shoot me an email and I'll give you some more information. And during these classes, I make a point to spend time answering people's questions. About 1/6 of the total class time is spent answering questions. And I try to go at a very decent pace so people can take a very, very good note. So if you're interested in any of these things, just shoot me an email and I'll be more than happy to point you in the right direction. So we're talking about metformin, right? So we're saying that metformin, lactic acidosis is a big side effect. And we kind of talked about the mechanism behind that side effect. So again, how can our friends at the MDMEs go after metformin some more? Well, one way they can go after metformin some more is they can come after it from the perspective of contraindications. But they won't make it like a clear-cut contraindication. They'll make it like a roundabout contraindication. Like, for example, if a person comes into the hospital in shock and they have diabetes, do you think it's going to be a very good idea to be giving those people metformin? Probably not. Because again, when you have shock, you're not perfusing your system's tissues very well. If you don't perfuse them very well, then you're going to be depending a lot. There's going to be hypoxia. If there's hypoxia, well, your electron transport chain is not going to be working very well. And if it doesn't work very well, then your TCA cycle is not going to be working great either. So your body is going to be like, well, I'm not getting enough oxygen. I need to depend on something that can help me with my oxygen. I need to make energy in some way that is non-oxygen dependent. Well, what does that sound like? That sounds an awful lot like glycolysis. So when glycolysis is happening at an increased rate, you're going to generate more lactic acid. Again, that lactic acidosis can potentiate the lactic acidosis you can get from metformin. So just you kind of want to be careful with that, because if a person has a condition where they are generating more lactic acid, that's almost like a barometer for, this person's tissues are not being well perfused. Well, at least whatever little perfusion your tissues have, you want those tissues, you want that blood moving around in your body, even if it's little, to have some measure of glucose in it. So it's not particularly smart to be inhibiting gluconeogenesis at the precise time where your body needs more glucose. So again, metformin, not a smart idea in people that are in shock. Metformin, not a smart idea in people that are getting iodinated contrast. If you're getting iodinated contrast, you're literally giving something that can sacrifice a person's kidneys. Again, if you're giving a kidney sacrificial agent, you should not be giving people drugs that depend on proper metabolism in the kidneys to function. Again, you just kind of want to be careful of some of these things. And then again, we've talked about, in terms of the lipid drugs, we've talked about the nitrates, we've talked about the statins, we've talked about niacin, we've talked about the bile acid binding resins, we've talked about the fibrates. The nitrates, they're not really a lipid drug, but that's how I kind of started. But again, don't forget your ezetimibe, right? Your drugs like ezetimibe. Ezetimibe is a drug that basically prevents the reabsorption of cholesterol. Again, if you don't reabsorb cholesterol, ultimately your hepatocytes are going to be like, wow, we don't have enough cholesterol going. So your body's going to express more LDL receptors on the surface of your hepatocytes, and that's going to bring more LDL. It's going to clear more LDL from the circulation. So again, one thing I think I want to say as I proceed further here is one thing our friends at the MBMEs love to do in terms of statins. So let me maybe throw this in here. In terms of statins, many times they will not put HMG-CoA reductase inhibitor as the answer to how does a statin work. They can literally put an answer that says increases the expression of LDL receptors on the surfaces of hepatocytes. So that's something you want to keep in mind. That may not be directly how it works, but that's indirectly what it achieves. Because basically, if you again make less cholesterol because you've killed HMG-CoA reductase, your hepatocytes will have a low intracellular cholesterol concentration. That's going to cause them to say, you know what, since we can't make cholesterol, we got to get that cholesterol from the periphery. So they will express more LDL receptors. So you have increased cholesterol clearance from the bloodstream, from the periphery. That's how those things lower LDL. That's how those things lower LDL. That's how those things lower LDL. So again, instead of putting HMG-CoA reductase inhibitor, one answer they can easily put is lowers intrahepatic concentration of cholesterol. Another answer they can put is increases the expression of LDL receptors on the surfaces of hepatocytes. Or another answer they can just put is increases LDL clearance from the periphery. Notice literally, I'm saying the exact same thing. I just literally said it 4 different ways. That's the concept of derivatives with the USMLE exams. They take what you know and just put it in other forms, just to see if you truly understand what's going on. So again, that's why you see me, I keep telling people, there's nothing wrong with Anki. Anki is amazing. Even for me, as a person that has been involved in education for a long time, I see the intrinsic benefits of Anki. But again, don't just memorize stuff. You need to understand what's going on. Many people, all they have in their brain is filled with buzzwords. If your brain is filled with buzzwords, you could have done well on the USMLEs of back in the day. But that's not the case with the USMLEs of this present time. Your brain, you cannot have a buzzword-filled brain and succeed on your USMLEs. No. You need to have a brain that, yes, has buzzwords, but also some of that space should, actually probably more space than the space you allocate to the buzzwords, should have understanding there. Because it's that understanding and ability to integrate that can really, really help you knock down questions on exams. Like you see some people, they struggle with biostats because they have a formula-filled brain. If you have a formula-filled brain, yeah, you may answer like a few of your biostats questions on the exams, or you may be lucky and get a form that has just plug and chug. But the thing is, many of the biostats questions these days are not plug and chug. In fact, many of them do not involve math at all. Many of them are like word problems where you actually have to like reason out and even realize that this is what they're testing from the scenario. Like literally, there are questions that will show up on an exam, on a USMLE exam. You read them, it's a biostats question, and people do not even know that it's a biostats question. Or if they realize that it's a biostats question, they do not even realize the concept that's being tested. They think that, this question is talking about negative predictive value, when the question is actually talking about specificity. But the thing is, all they know about specificity is the formula. They don't know how to integrate specificity. They don't know how to reason through specificity. Like literally, the MBMEs can write a D-dimer question, and it's literally a biostats question. Again, you got to learn to reason through these things. You got to learn to reason through these things. And since I guess we're talking about the LDL receptor, we're saying that, if you express more LDL receptors on the surfaces of your hepatocytes, then you will clear more LDL from your circulation. If you clear more LDL from your circulation, then you're going to lower your LDL. So that means persistence of the LDL receptor on the surface of a hepatocyte is a good thing. It's literally a good thing. So what is the thing that makes those LDL receptors to be endocytosed and recycled? Well, it's an enzyme known as PCSK9. So PCSK9, it basically does what you don't want if you're trying to lower your LDL. Literally, its job is to cause you to endocytose said LDL receptor and then break it down. Your body doesn't just lose all the proteins and amino acids and everything in the LDL receptor. It actually does recycle them. So it kind of reduces the number of LDL receptors, if you may, on the surface of your hepatocyte. So what is one effective way to counter that problem? Well, one effective way to counter that problem is to shut down PCSK9. If you shut down PCSK9, then your LDL receptors will have almost like a bigger, longer half-life on the surface of your hepatocytes in a sense. So that's where drugs that all end in QMAP, right? Like evolocumab, alirocumab, they are PCSK9 inhibitors that we use to actually manage a person's hyperlipidemia. Okay, so I think I'm going to stop this Farm Blitz podcast. We'll see what happens in the future with timing, my schedule and stuff. I'd be happy to maybe have another Farm Blitz podcast. I think this is actually a pretty good format. You get to review a lot of, not just farm, a lot of pathology, a lot of physiology, a lot of pathophysiology, all very, very short time frame. So I'm going to go ahead and stop here. Again, I go over one-on-one tutoring for all the USMLE exams, step 1 to 3. Preclinical med school exams, third-year shelf exams. I offer review courses for step 1. I literally have one starting next week. For step 2 and step 3, I literally have one starting next month. I have a biostatistics bootcamp. I have a social sciences and ethics review. And then I also help with applications, mock interviews, rec letters, personal statements, things like that. So if you're interested in any of those things, just shoot me an email and I'll be happy to point you in the right direction. I also have these podcasts on the 3 major podcast apps: Apple Podcasts, Google Podcasts, and Spotify. At least the first 3. At least those major three apps. At least the most recent 150 podcasts are on there. Really, if you want everything from episode 1 to 432, you got to go on the website. Those podcast apps, they just don't really let you put more than 150 episodes at a time. And then I have a YouTube channel, Divine Intervention USMLE Podcasts and Videos. That's where I post the videos I make. And actually, I've been uploading a lot of my podcast material as well on that YouTube channel. So please subscribe to that YouTube channel. Just every bit of support certainly helps. And please spread the word. If you've gotten benefit from this podcast, don't hide it, Don't hide it from yourself. Spread the word with other people. And then I also have another website called divineinterventionlifelessons.com. That's a website where I post the life lessons that I make. Many people say that, wow, Divine, I love the life lessons that you post at the end of some of your mainstream podcasts. But so I decided to make a new website, divineinterventionlifelessons.com. In fact, there's an Apple podcast associated with it. If you look on Apple Podcasts, it's called the Divine Intervention Life Lessons Podcast. And it's Bible-based. Every week I post 2 podcasts. They're 10 to 20 minutes long. And they address like just a common problem that people face from a biblical perspective. So I really hope you find that to be helpful. So thank you for listening to me today. Again, as we wrap up the year, today is December 29th. I'm just going to encourage you, even if you've screwed up, today is December 29th, so we've gone through like 362 days already. We're on the 363rd day. If there are stones that you've left unturned all throughout the year, you still have 3 days to turn those stones. If you've been moving in the wrong direction all throughout the year, you can make a change now. The thing is, many people believe so heavily in New Year's resolutions. Again, there's nothing wrong with New Year's resolutions. So I guess there's a life lesson. There's nothing wrong with New Year's resolutions, but the time to make a change is now, not when the new year starts. You see, some people, they literally want to wait till the new year. Let me tell you this. The more time you spend going in the wrong direction, the more time you will spend having to reverse those bad decisions. That is the truth. That's why, to be honest with you, again, nothing wrong with the concept of a New Year's resolution is fine, but you don't have to wait till January 1st to start making a positive change in your life. You can make a positive change in your life starting now. There's even this part of the Bible that says now is the time of salvation, like literally now, not tomorrow, not next year. Because let me tell you this, you can't guarantee tomorrow. You literally cannot guarantee tomorrow. And you may not even realize this. An opportunity that you were like, oh, I'll prepare for that opportunity with my New Year's resolution. It can be an opportunity that shows up for you on December 31st. But if you are prepared on December 29th and 30th, you can take advantage of that opportunity that shows up on the 31st. So I'm telling you, like, maximize your time. Maximize your now. Don't waste your now. Don't keep looking to start maximizing the future, and then you're underutilizing the present. That's not a smart idea. Because think about it. Say, for example, you were supposed to take an exit on a highway, and then you don't take that exit, and you keep driving till 10 exits later. Yes, you can still get back to your original position, but it's going to take you a longer time to get to your destination. That's the same thing with people that keep saying, oh, I will make a change next month. I'll make a change next week. I'll make a change next year. That time will probably never come. The time to make a positive change in your life is literally now. Take that exit now. If you take the exit now, at least whatever backtracking you need to do from the mistakes you've made all along, the backtracking period will be shorter versus a longer backtracking period. Yeah, because there's this intrinsic motivation you see people have, like, wow, once the new year comes, I'm going to change my ways. No, it's not the new year coming that will make you change your ways. It's you truly changing your ways that will make you change your ways. Or you see some people, they are like, oh, if I move to a new city, all these problems will disappear. No, yes, there are some times where a move is warranted, but many times all people need to do is stay in the same spot they're in, but just make a change. Stay in the same city, but make a change, and their lives will get better. But I think I'm going to go ahead and stop here. This is almost 40 minutes already. But just make a change. You can start your resolution now. You don't have to wait 3 more days to start that resolution. So thank you for listening to me. I hope you're blessed by this podcast. I'll see you in the next episode. God bless you. Bye for now. Thank you.